Hi, I'm Dr. Bill Adams from the PlasticSurgeryChannel.com, and we're at yet another roundtable discussion where you get the real answers on new plastic surgery topics and procedures. With me are three internationally renowned plastic surgeons from the PlasticSurgeryChannel.com, and they're going to give you the real story on plastic surgery pain management. Steve, is pain a real issue for plastic surgery patients?
I think particularly for plastic surgery patients, it's a problem because they typically don't come to us with pain. Any pain they have is from the procedure that we deliver. So I think for us it's really important. I always tell the residents and I tell our nurses that the easiest kind of pain to tolerate is always someone else's. So anything that's new and can add to pain management is a plus for us.
Lee, what do you think?
I agree. I think, people come to plastic surgeons for a procedure that makes them look better, that makes them feel better. And oftentimes they have a little bit of the attitude that it's like going to the salon for a hair treatment. And it's not. It's real surgery. And sometimes patients really find that out for the first time, even though it may have been explained to them. They find it out after the procedure. So anything that we can do to make the patient's experience more comfortable is a big plus for us.
So Richard, pain is a deterrent for people to have plastic surgery.
Well, I think that's absolutely right. People will have heard from their friends that who've had a procedure that it was painful, and they may never pick up the phone to make the appointment for the consultation because they've just already decided that's just not something I'm going to do.
Okay, so you guys have convinced me that it's an important issue. So what do we do as plastic surgeons to manage post-operative pain? Steve, you want to start?
Well, I think currently what you want to do is have good anesthesia in the OR. I mean, that's really where it starts, and have good preparation of the patient. But once you're out of the operating room, you want to make sure that the patient is supplemented either with oral pain medicine or anything else that's available.
So oral pain medicine, everybody knows about that type of thing. What other things other than just pain medicine, Lee, are out there for us to treat patients with?
Well, we've had a lot of studies over the year evaluating pain, both in plastic surgical procedures and in surgery in general. And it's clear that a multimodal approach to pain management is the best way to go, which, as Steve mentioned, starts in the operating room with good anesthesia. Post-operatively, they're going to use oral pain medications, but also regional pain blocks or pain administrating agents in the operating room that last afterwards are a big plus in many procedures.
Richard?
Yeah, I think it's so important for the patient to wake up pain-free, to kind of have that initial experience that's going to define their post-operative course. And, there's also surgical technique. As plastic surgeons, we believe in handling the tissues gently, doing all these things that lead to less tissue trauma so there's less pain to begin with.
Yeah, I was going to ask about that specifically. So technique-wise, precise techniques, less bleeding, less trauma, do you guys feel like that contributes to less pain?
Oh, absolutely, because any time rough tissue handling takes place, any extra bleeding, those kind of things, finer techniques certainly is more comfortable to the patient.
Yes, and I think probably the literature would support that as well. What about other modalities that are out there? There's anesthetics that we inject, both short-acting, long-acting. What are your thoughts on that, Steve?
Well, certainly we've all used short-acting anesthetics. We use them in the clinics on wake patients all the time, and we've used them now in the operating room on patients that are asleep just to prolong the anesthetic afterwards, and we're fortunate to have now longer-acting available anesthetics.
So when people talk about a local procedure, Lee, if you're having a mole taken off, you're in the doctor's office, is that a local anesthetic?
That's right. We use typically lidocaine for that, which is a very short-acting local anesthetic that's injected. Patients do experience some pain or discomfort upon injection, but it basically works very quickly. There are other locally injected anesthetics like Marcaine or bupivacaine that last longer. So,
Richard, any thoughts on that?
Yeah, I think that's been the standby, put that in at the time of surgery, and if you use it at the beginning of the case, their anesthesia can be a little bit lighter. I'm talking about cases where there's IV sedation or general anesthesia, but that's definitely been the standby in terms of getting the patient to wake up pain-free.
Okay, so Marcaine is something many people are familiar with. How long does that last?
4 to 6 hours, depending.
Okay, and it's injected into the surgical site.
Yeah.
Okay. Lee, let's talk specifically about some other modalities. There's pain pumps. Tell us a little bit about what's a pain pump and what's your experience with it.
Well, a pain pump is a very thin catheter that is placed at the time of surgery into a specific area where you've had the surgery, and we choose where that is based on the procedure and what nerves we're trying to block. And usually it gives a slow administration of one of these local anesthetics over time to a specific area. They came about 12 to 15 years ago and kind of had a big rise in popularity, and at least in my practice those have kind of dropped off a bit. I don't use them as I used to. I don't know about you all.
Steve, are you using pain pumps?
We've really shied away from it. There's a cost involved, and there's also a fact that it's quite cumbersome. So most patients would rather not use a pain pump, and we've gone back to just local injections.
So there has been, I think, some studies showing the efficacy of pain pumps for managing postoperative pain. Is that true, Richard?
Right, I think that's definitely true, and I have personally found it most useful for tummy tucks, abdominoplasties.
Mm-hmm. Okay, one thing I wanted to spend some time talking about is a new product that's just been released in the past month. It's a liposomal bound Marcaine product called Exparel. Richard, tell us a little bit about what is this product and a little bit about the science of it.
Well, it is bupivacaine, which is a well understood numbing agent. It's bound in these liposomes, little particles that release it slowly for up to 72 hours. So in a lot of ways it's like having a pain pump, except that you don't have any external apparatus. You inject it into the surgical site at the time of surgery.
Now my understanding is that the studies that they did, and we'll get into a little bit of the safety part in a bit, but the studies they did were on non-plastic surgery procedures. Does that translate to plastic surgery procedures?
I think it does. There will be more studies ongoing specific to plastic surgery, but there are well understood models of surgical pain, and that's a logical place to start when you're looking at an agent like this. So these are things like hemorrhoidectomy, where we really know what their typical pain requirements are in terms of need for medication and so forth. And there have been a number of studies on that that really prove the concept pretty well for this product.
Okay. Lee, I want to stay on the topic of science and studies and safety, because I know a lot of surgeons hear about Marcaine and the whole topic of cardiac toxicity and safety comes up. So what do we know about the safety of this product?
Well, we know actually quite a bit. The company has done their homework, and we have good, well done studies on safety of this product. You know, Marcaine can be a scary drug. It's a drug that if it gets into the intravenous system can cause very, very difficult to treat cardiac arrhythmias, and we've all been preached that since early in our training. So the company basically took Marcaine and their drug, Exparel, and followed over time the levels, giving different injections or different amounts of the drug in patients, and actually the levels stay very safe throughout. Despite doing it double, and in some cases more than double, the usual dose of Marcaine.
So let's shift now from studies and science to the clinical use. Steve, I know you've had significant experience, early experience with this product. Tell us a little bit about what you've seen.
Well, in the last month, we've done 9 patients for abdominoplasties at our office and used Exparel. And initially, my very first patient that I used it on came back and said that the augmentation mammoplasty I had done 7 years ago on her was more uncomfortable than her abdominoplasty. And that's the first time I've ever heard that. We all have patients that have had both, but they always say the abdominoplasty is much more uncomfortable. This patient thought it was not as uncomfortable as an augmentation. My other experience has been too with circumferential abdominoplasties. We're doing these all as outpatients, so it's really important to us to get the person up, moving around. It's great to decrease their narcotic use. It's also great to have them ambulatory so we don't have to worry about blood clots. But truthfully, with this kind of a material, that people are bounding back in the next day to see me, they're walking normally, and they're very comfortable.
Richard, how about your clinical experience with this?
Yeah, I've been using it on abdominoplasty patients, and I've had a similar experience. It has dramatically cut down on their need for narcotic medication afterwards, probably by 50% or more. They feel better. They get up and ambulate faster. I think it's been pretty really satisfying in that regard. I use it on augmentation patients as well. I do think it makes a difference for them as well.
Lee, how about you?
Yes, similar experience. And you know, the one thing that I would say is we all know that Marcaine works, and we've all had experience with Marcaine in the past. It's just that we get a little nervous about injecting amounts that we think are going to give an adequate pain relief, and also when it's only lasting 4 to 6 to maybe 8 hours at the longest, that's not really accomplishing. And the thing that we've noticed is, you know, it's very simple. It's Marcaine. We're familiar with that. It's, for some reason, it appears that the toxicity is less when it's microsomally bound. And we all know that when you have problems with Marcaine, you rescue it with lipids. So this may be a correlation as to why, although I've not seen that specifically. But it's Marcaine that lasts 2 to 3 days. You know, so it's a really simple, straightforward correlation. It works.
Okay. So it sounds like it definitely has good potential. What procedures, is this something that we should be using in every procedure, or what procedures do you guys feel like it fits into best? Steve, why don't you start?
If I were going to use it for the very first time, I'd do exactly what I did and use it on abdominoplasties. We're all used to injecting during abdominoplasties. It's very simple. The material comes in a 20 cc aliquot, which is essentially its maximum dosage. I have diluted that up to about 80 cc's of total material, and then injected it not only in the incision site itself, but also into the rectus fascia, into the intercostals, and I've gotten great results doing it that way. I think that's a great place for a surgeon to start, is with an abdominoplasty.
Richard, you agree with that?
I do. I think other potential uses are going to be in revision breast surgery and breast reconstruction, particularly when you're using an acellular matrix, because the sutures into the chest wall can be pretty tender for a while, and I think that can help get patients out of hospital sooner. And when you're doing one of these revisions in office, it makes a huge difference.
It used to be people would stay in the hospital for days for pain management. Now the insurance companies won't even cover people to stay a day, so this may have huge application to help patients with that. Lee, any thoughts on what procedures you may consider using this on?
Well, I totally agree with abdominoplasty. I agree with revision breast. I think those are both good areas to start. I think that there are a subgroup of patients, even with primary breast augmentation, which incidentally they do have some studies on primary breast augmentation, not only with pain relief of Exparel versus Marcaine, but also with evaluating potential problems as far as 2 years out related to the breast aug, such as capsular contracture and other issues, and it's been very good in the literature so far. You know, I think that it makes sense that this will extend into reconstructive procedures like breast cancer reconstruction, tram reconstruction of the breast, where typically we've had patients in the hospital for a fairly prolonged period of time. And you know, the truth is, for most of these, once you realize that they're stable after a big procedure, pain is what's keeping them in the hospital. And so if we're trying to cut costs and get the patients out of the hospital to prevent infection and other things, it's a great use for this drug. Hopefully we'll begin to use it for that before long too.
That sounds great. Well, one thing I think you guys have clearly taught me is that pain is a big deal, and that there's things that we can do, and maybe some of these new advances can fit into our armamentarium and making things better for the patient, which is what it's all about. So I thank you for coming and sharing your expertise with us and our viewers. And I think that I certainly have learned a lot, and I hope you have as well. If you'd like to learn more, please visit us at theplasticsurgerychannel.com, and we'll see you next time.